Welcome to the Rad-Onc Smart Review Head and Neck Cancer series.
Today we are tackling episode 24, Nasopharynx 4 Response Assessment and Salvage.
So in the last few sessions, we've built the foundation. We've gone through the anatomy, the EBV biology, staging, all the way up through concurrent chemoradiation. But now we get to the moment of truth. The treatment is done, the mask is off, and the patient looks at you and asks that one question: did it work?
And, right behind that is the physician's question, the one that keeps us up at night. What do we do next if it didn't?
This is really the high-stakes part of it all. Recurrent NPC isn't just another clinical problem. It's a minefield. You're at this fork in the road, and your choices are surgery, re-irradiation, or systemic therapy.
And if you choose the wrong path, the consequences are just catastrophic.
Yeah, that's not an exaggeration at all, is it?
Not in the slightest. I mean, we're talking about a situation where treatment-related mortality, so death from the cure, not the cancer, can be over 10%. You're staring down these absolute terrors like carotid blowout syndrome, temporal lobe necrosis, massive nasopharyngeal hemorrhage.
These aren't just things you read about in a textbook. They're life-ending events. So our mission today has to be about creating a survival guide.
Right.
By the end of this, you need to know how to assess response properly, when to step in, and maybe most importantly, how to talk a patient through what is, frankly, a life or death decision.
Let's ground this with our case. Let's bring back Mr. Chen.
Right, Mr. Chen. So he's a 48-year-old Chinese man. We saw him 18 months ago. He came in with a T3N2M0 nasopharyngeal cancer.
And it was that classic non-keratinizing, undifferentiated type.
Exactly. And just to jog everyone's memory on his treatment, he got the standard of care. 70 grade to gross disease, 59.4 to high risk, 54 to low risk.
And he got through his chemo 3 cycles of concurrent high-dose SIS pleptin.
His biomarkers were also textbook. Pre-treatment, his plasma EBV DNA was up at 12,000 copies per milliliter.
And then after treatment, at that 3-month mark, everything looked great. EBV was undetectable, the PET CT was totally clean, a complete metabolic response.
So he goes on surveillance.
Right.
And then, 18 months later, he comes back. New complaint. Right-sided nasal obstruction.
And you scope him, and there it is, a suspicious lesion right in the fossa of Rosenmiller on that right side. You biopsy it, and it's confirmed. Recurrent carcinoma.
The liquid biopsy confirms it, too. His EBV DNA, which had been 0, is now back up to 8,000 copies.
So, okay, we have to restage him. And this is where the MRI is just so critical. It shows a 1.8 centimeter mass, but it's confined. No skull base invasion.
And the PET CT lights up right there in the nasopharynx, but the rest of him is clean. No nodes, no distant mates.
So this is it. This is the scenario that puts us right in the hot seat, and it boils down to 4 questions for Mr. Chen.
Okay.
1, is he even a candidate for a curative intent salvage? 2, if he is it surgery or is it more radiation?
3, what are the real, honest outcomes and risks we need to tell him about?
And 4, how does this whole conversation change if that tumor was just a little different? If it was touching the skull base or if he had a spot in his lung?
Before we dig into all of that, let's just pause and hear how a resident needs to present this whole situation, under pressure in an oral board exam.
This is a 48-year-old man with locally recurrent EBV-positive nasopharyngeal carcinoma, non-keratinizing, undifferentiated type, presenting 18 months after definitive chemoradiation. Recurrence is isolated to the nasopharynx without skull base invasion, nodal involvement, or distant metastasis. Restaging is complete with MRI of the skull base and PET CT, and plasma EBV DNA confirms disease activity at 8,000 copies per milliliter. Given the disease-free interval exceeding 12 months, small tumor volume, favorable anatomic location without internal carotid abutment, and absence of retropharyngeal or distant disease, this patient is a candidate for curative intent salvage. Level 1 evidence from a randomized trial suggests endoscopic nasopharyngectomy offers superior overall survival compared to re-irradiation for resectable recurrence. If surgery is not feasible, re-irradiation with hyperfractionated technique, 65 gray and 54 fractions delivered BID, is preferred over standard fractionation based on improved survival and reduced treatment-related mortality. I would counsel extensively on risks, including temporal lobe necrosis, nasopharyngeal hemorrhage, and carotid blowout syndrome.
That's a fantastic summary. Really hits all the key decision points. So let's peel that back now, layer by layer, starting with just assessing the response in the first place.
Sounds good.
There's this paradox with NPC, right? We always talk about how radiosensitive it is, but then following these patients is just incredibly complicated.
It really is a paradox. With modern IMRT, our local control is amazing. Like, less than 10% of patients recur in the head and neck.
Which is phenomenal.
It is. But NPC has this really nasty habit of metastasizing. It's got the highest rate of any mucosal head and neck cancer. We're talking up to a third of high-risk patients will eventually fail somewhere else in the body.
So that totally changes your surveillance mindset. For, say, a larynx cancer, I'm almost entirely focused on the neck. With NPC, I have to even think systemically: lungs, bone, liver.
Precisely. You need that systemic surveillance. But you also can't take your eye off the primary site, which is notoriously tricky to evaluate after treatment.
It's just a mess in there.
It is. It's a deep, dark space. And after 70 grays, you've got fibrosis, crusting, the anatomy is all distorted. And on an MRI, post-treatment changes can look a lot like tumor.
And that leads directly to what I think is a huge trap for trainees: imaging way too early. Can you talk about the 12-week rule?
This is non-negotiable. This should be doctrine. You do not get a restaging PET-CT until at least 12 weeks after finishing radiation.
And why is that?
Because if you scan at 4 weeks or even 8 weeks, you are guaranteed to see FDG uptake. And that's not cancer, that is inflammation. It's the body's cleanup crew, the macrophages doing their job.
So if you act on that inflammation, you're making a huge mistake.
A catastrophic one. You cause incredible anxiety. You end up chasing these false positives. And worst of all, you might be tempted to biopsy healing tissue, which is just asking for osteoid necrosis. So you wait.
Okay, so we wait 12 weeks. We get the scan. Are we just relying on the PET-CT?
No, absolutely not. The PET-CT is great for finding distant disease, but for the local site, it just doesn't have the resolution. The brain itself has high background uptake.
Right.
You need the MRI of the skull base. You have to see the tissue planes. You need to know if there's subtle bone destruction, if it's creeping towards the cavernous sinus. You just can't see that on a PET.
So let's say we do all that. We wait. The MRI comes back, and it's a bit fuzzy. Maybe some asymmetry, but not a clear, obvious mass. What's the move?
If it's equivocal, you have to get tissue. You just can't commit the patient to the kinds of toxicity we're talking about for salvage based on a suspicion. You need a biopsy. You need tissue confirmation.
And this is where NPC gives us this unique tool, this sort of superpower that other head and neck cancers don't have. The liquid biopsy?
The EBV DNA kinetics, yes. This is a complete game changer for surveillance. In endemic NPC, it's a validated biomarker that can predict a recurrence months before we'd ever see it on a scan.
Can you break down the numbers for us? What are the key thresholds we need to know?
Okay, so pre-treatment, the big numbers to think about are around 1,500 and 4,000. If your level is less than 1,500 copies per milliliter to start, your 5-year overall survival is great, something like 87%.
And if it's high?
If it's over 4,000, your survival drops to around 70%. So it's prognostic right out of the gate.
But for surveillance, it's not the starting number that matters as much as the trend, right? The clearance.
Exactly. It's all about the kinetics. Ideally, you want to see that number just crash. If it's undetectable by the time radiation is done, that's the best prognostic sign you can have.
And if it's slower to clear?
If it's still detectable at the end of treatment, but it clears by, say, 6 to 8 weeks, that's more of an intermediate prognosis. The real danger zone, the big red flag, is if it's still detectable at that 6 to 8 week mark post-treatment.
So that's the siren going off.
It really is. Persistent detection is a very powerful predictor for both locoregional failure and for distant mets.
Okay, so the logical next question is, if the EBV is still high after radiation, why don't we just, hit them with more chemo? Try to mop up whatever's left.
It's a perfectly logical thought, and it's exactly what the NPC 0502 trial was designed to answer. They took those patients, the ones with persistent EBV DNA, and randomized them to either adjuvant, gem, SY-tubin, and SIS-Plutin, or just observation.
And what did they find?
Nothing. It was just heartbreakingly flat, no improvement in any outcome. The 5-year recurrence-free survival was stuck at around 50% in both arms.
So the big takeaway there is that it's prognostic, but not predictive of response to more chemo.
That's a perfect way to put it. It's a thermometer, not a thermostat. It tells you how hot the fire is, but you can't cool the fire by messing with the thermometer reading.
So Practically speaking, how do we incorporate this into our routine follow-up?
The standard protocol for endemic NPC is to check the EBV DNA every 3 to 4 months for the first 2 years, then stretch it to every 6 months through year 5. And you layer that on top of your regular exam and scope.
Just like what happened with Mr. Chen. That rising number was the smoke, and then the scope found the fire.
Exactly.
Okay, so we found the fire. We have a confirmed local recurrence. Now we have to figure out how to put it out. You mentioned an if-then ladder, a decision framework. I like algorithms. Can you walk us through it?
Sure. Think of it as escalating rungs on a ladder. Rung 1, the best case scenario. If the recurrence is local, confined, and this is critical, more than 5 millimeters from the internal carotid with a good disease-free interval, then the preferred salvage is endoscopic nasopharyngectomy.
Okay, surgery first. What's rung 2?
Rung 2 is if it's local but it's unresectable. So now it's encasing the carotid or invading the skull base, but the patient is still in good shape. Then we consider re-irradiation, and specifically with a hyperfractionated technique.
And if the recurrence is just in the neck nodes?
If it's only regional nodes, then it's a neck dissection. Surgery leads the way. You might consider adding radiation after, but the primary treatment is to cut it out.
Makes sense. And distant disease?
If it's distant, then it's systemic therapy. At that point, any local treatment is just for palliative reasons. You're not going for a cure with local therapy if there are mets.
And the last rung. When do we just say stop? When is salvage too dangerous?
That's if the patient already has severe late effects from the first round. Active necrosis, exposed bone, cranial nerve damage. You do not re-irradiate that. And the absolute no-go is a combination of carotid encasement, a short disease-free interval, and existing necrosis. That is just a recipe for a fatal bleed.
Let's go back to rung 1, because that's a big deal. You said surgery is preferred over radiation for local recurrence. That's a total reversal from the primary setting where we almost never operate.
It is a complete flip.
Yeah.
And it's because we now have level 1 evidence. There was a phase 3 randomized trial comparing endoscopic surgery to IMRT re-irradiation for these resectable recurrences.
And the results were definitive.
They were not subtle. The 3-year overall survival was about 86% for the surgery group versus 68% for the re-irradiation group.
That's a nearly 20% survival benefit. I mean, in oncology, that's a massive difference.
It's a canyon. And here's the kicker. It wasn't just that surgery was better at controlling the cancer, it was that surgery was safer.
What do you mean by that?
Look at the treatment-related mortality. In the surgery arm, it was around 3%. In the re-irradiation arm, it was about 12%.
Wait, say that again. 1 out of every 8 patients in the radiation arm died from the treatment.
That's right. Died from hemorrhage, necrosis, infection, not from the cancer. And the quality of life data tells the same story. Bad mucositis was 5% with surgery versus 26% with re-irradiation.
So it's a slam dunk. Surgery is cleaner, safer, and works better.
If the patient is a candidate. And that if is doing a lot of work there.
Right. What makes someone a candidate?
The tumor has to be technically resectable. That means you need that 5 millimeter buffer from the carotid. It can't involve the retropharyngeal nodes. And honestly, you need to be at a center with a surgeon who's an expert in endoscopic skull base work. This is not a casual operation.
So for our patient, Mr. Chen, with his small central recurrence, surgery seems like the clear winner. But let's say his tumor was right up against the clavus, or he just refuses an operation. Now we're on rung 2, re-irradiation.
Okay, if we have to go down that road, we have to be smart about it. The standard once-a-day fractionation we use up front is not the way to go. The standard of care for salvage is hyperfractionation.
And the thinking there is what? Sparing normal tissues?
Exactly. It's all about improving the therapeutic ratio. Those late-responding tissues, brain, nerves, blood vessels, have already taken a 70 gray hit. By giving smaller doses per fraction, you allow for more repair in between doses for those normal tissues, while still delivering a killing blow to the tumor.
And there's a trial for that, too.
There is. A phase 3 trial that compared 65 gray in 54 fractions given twice a day BID versus a more standard 60 gray in 27 fractions once a day.
And hyperfractionation came out on top.
It did, convincingly. The 3-year overall survival was about 73% for the BID arm versus 54% for the daily arm. And again, look at the fatal toxicity. It dropped from over 8% down to 1.6% with hyperfractionation.
So smaller bites more often saves lives.
It absolutely does. It's a bigger logistical lift for everyone involved, but the data is just undeniable.
Let's talk about the actual planning. This can't be a simple plan.
Not at all. The margins are razor thin. You know, for a primary tumor, we might take a 5 millimeter or more CTV margin. Here, we're talking 5 millimeters or less. And if you're up against the brainstem or the optic nerve, the margin is 0. You are painting right on the line.
What about the neck? Do we treat the elective nodes again?
No, absolutely not. That is a critical point. There is NO, elective nodal irradiation, in the salvage setting. The toxicity would be prohibitive. You treat the gross tumor volume, the cancer you can see, and that's it.
I really want to drill down on the constraints. The brain has a long memory. It remembers that first 70 gray.
It does. And the temporal lobes are the most vulnerable. So the hard constraint from that hyperfractionation trial was that the D1%, the dose to the hottest 1% of the temporal lobe, must be less than or equal to 54 gray.
And that 54 gray number is to prevent what, specifically?
To prevent temporal lobe necrosis, TLN. It is the signature devastating late effect of this treatment.
Describe what TLN looks like for a patient.
It's just tragic. It usually shows up a few years after the primary treatment, but re-irradiation puts it on fast forward. The median time to TLN after salvage is only about 15 months.
And the symptoms?
It starts with cognitive changes, memory problems, personality shifts, and it can progress to full-blown seizures, symptomatic epilepsy.
What are we looking for in the MRI?
You see this characteristic finger-like white matter edema on the T2 images. It can look a lot like recurrent tumor, actually. Sometimes you need an MR spectroscopy to tell them apart.
And the treatment for it is what?
It's tough. We try high-dose steroids first. Maybe a third of patients respond. Hyperbaric oxygen can help. There's some data for bevacizumab to reduce the swelling. And in the worst cases, you might actually need surgery to resect the dead part of the brain.
Just awful. But there is one thing even more feared than TLN.
The carotid blowout.
Yes. This is the absolute nightmare scenario.
It is. So we all know radiation damages blood vessels, causes stenosis, but a blowout is a full-thickness rupture.
Why does it happen in this specific setting? What's the mechanism?
It's what I call the encasement dilemma. Picture a tumor that has grown around the carotid artery. It's invaded the vessel wall. At that point, the tumor is the wall.
Okay.
Now you come in with your 65 gray of radiation and you kill the tumor. The tumor melts away. So what's left holding the blood in?
Nothing. Just a weak, irradiated necrotic wall.
Exactly. The structural scaffolding is gone. The vessel ruptures. And you have a massive arterial hemorrhage into the nasopharynx that is usually fatal in minutes.
Which brings us right back to your no-go scenario. If you see carotid encasement on that pre-salvage scan,
you have to have a very, very serious conversation about whether curative intent re-irradiation is even possible. The risk is just too high. In many of those cases, palliative systemic therapy is the safer, more appropriate path.
Let's touch on that briefly. If Mr. Chen had distant Mets, or if both surgery and radiation were deemed too dangerous, what's the systemic therapy plan?
For a long time, the backbone has been gemcitabine and cisplatin. Gemcis, that was the standard. But now, in the modern era, it's all about immunotherapy.
So adding a PD-1 inhibitor to that backbone.
Precisely. The Jupiter-02 trial showed adding toripalimab to Gemcis improved survival. There's also the Captain First trial with chemoradiation. So today, chemoimmunotherapy is the standard for metastatic or incurable disease.
Okay, let's circle all the way back. Let's apply this to Mr. Chin, sitting in your exam room.
Yeah.
He's got the long disease-free interval, the small local recurrence, no Mets.
Right. He's got all the favorable features you'd want to see.
So what's your recommendation? What's the plan?
Option A, the preferred option, is endoscopic nasopharyngectomy. I'm calling a high-volume skull-based surgeon today. That survival advantage, 86% versus 68%, is just too significant to ignore, and it's safer.
And if, for whatever reason, the surgeon says he's not a candidate?
Then we pivot to option B, hyperfractionated re-irradiation. 65 gray and 54 fractions, twice a day. But surgery is first.
How do you actually explain this to him? He's terrified? He thinks he's out of options?
I'd sit down with him and say, Mr. Chen, the cancer is back in one small spot, but we've caught it early and it hasn't spread. This means we have a real chance to cure this again. Now, based on the best science we have, the safest and most effective option is a specialized surgery to remove the tumor through your nose. The other option is more radiation, but a second course of radiation carries some very serious risks, about a 1 in 10 chance of major damage to the brain or a blood vessel. Surgery can help us avoid many of those risks. So the first step is for me to have our surgical team see you right away.
I like that. It's clear, it's honest, it sets expectations, and it gives him a concrete next step.
And it gives him hope, which is appropriate in his case. This is a potentially curable situation.
Okay, before we finish up, let's just do a lightning round on nodal map and volumes for salvage, just to be absolutely clear.
Okay, so when you're staging, you evaluate the retropharyngeals in levels 2 through 5. But when you are contouring for treatment,
No elective nodes.
no elective nodes. I can't say it enough. You treat the gross tumor volume with a tight margin. That's it. If there are positive nodes, they get a neck dissection. You do not irradiate the whole neck a second time.
Perfect. Now for the oral board traps. The classic mistakes. Trap number 1.
The itchy trigger finger. You get a PET CT at 4 weeks, you see some uptake. The trap is to call it recurrence and treat it. The right move is to wait. Repeat the scan at 12 weeks. Do not treat inflammation.
Trap number 2.
The hero complex. This is trying to re-irradiate an impossible situation. A patient recurs at 8 months. Tumor is wrapped around the carotid. The wrong answer is to offer curative radiation. You fail the boards. The right answer is to recognize the prohibitive risk and pivot to systemic or palliative care.
And trap number 3.
The radiation default. This is ignoring the surgical evidence. You have a perfect surgical candidate, small resectable recurrence, and you just default to re-irradiation because that's what you do. Wrong. Surgery offers better survival. You have to consider surgery first.
Okay, let's hammer this home with some high-yield board pearls.
Pearl number 1. EBV DNA is your liquid biopsy. High pretreatment or persistent post-treatment is a major warning sign.
2.
Wait 12 weeks for post-treatment imaging. Respect the rule.
3.
Surgery beats re-RT for resectable local recurrence. Remember the numbers. 86% versus 68% survival.
4.
If you must re-irradiate, use hyperfractionation. It significantly cuts fatal toxicity.
5.
No elective nodal irradiation on a salvage plan, GTV only.
And the last one, number 6.
Protect the temporal lobes. D, 1% less than or equal to 54 gray is your goal in the retreatment setting.
All right, time for the board blitz. I give you a scenario, you give me the answer.
Let's do it.
Question 1. A patient is 12 months out. Her EBV starts to creep up to 3,000 copies. PET CT is negative. She feels fine. What do?
You watch and wait. Repeat the EBV in 4 to 6 weeks and follow her very closely. You don't treat a number, and you don't do blind biopsies yet.
Question 2. 60-year-old man recurs at 2 years. It's unresectable, less than 3 millimeters from the carotid, but he has a good performance status. What's the plan?
Re-irradiation with hyperfractionation. 65 gray in 54 fractions, BID. Surgery is too risky, but his long disease-free interval makes a curative attempt with radiation reasonable.
Last one. You're counseling a patient about the risks of re-irradiation. What specifically do you tell them about temporal lobe necrosis?
I tell them it's a real and significant risk, that it can happen relatively quickly, about 15 months on average, and that we design the plan specifically to keep the dose to the temporal lobe under 54 gray to minimize that risk, but it can never be 0.
Fantastic. We have covered a huge amount of really complex material today.
Yeah, I think to sum it up, use your liquid biopsy, wait 12 weeks to image. If it recurs and it's resectable, surgery is king. If you have to radiate again, use hyperfractionation. And always, always respect the organs at risk.
And maybe a final thought here is that in this setting, technical skill is obviously critical, but judgment is everything. Sometimes the bravest, most expert thing to do is to look at a scan with carotid encasement and just say, no.
I couldn't agree more. Recognizing that line between salvage and harm is everything.
Next time in episode 24B, we are heading into the planning room for a nasopharynx planning workshop. We'll be talking skull base abutment, OAR trade-offs, and adaptive replanning.
Complete practice oral boards at radongsmartlearn.com and subscribe to Radong Smart Review for our next episode. Thanks for tuning in.